This is a SAM session titled as Radiology Imaging Research and Health Policy Research. And Dr. King Lee and myself are going to moderate this session. And may I invite King Lee to introduce the first speaker.
Before I introduce the first speaker, because this is a SAM session, I have to read some instructions to you. If you are planning to take this course for self-assessment module credit, please check in with the staff at a table near the door of this meeting room to verify your SAM's registration and receive your test document. And so if you are a member of the AUR, there will be no fee. But if you are not a member and you want the SAM credit, they will charge you $50. So you have to print your name and email address on the test document, and then you have to hand in your test document at the end. To receive the SAM credit, you must complete the test. There's no minimum score requirement, so all you have to do is answer every question. You can say all A or B, and you still get the credit. And approximately 6 weeks after the meeting, a SAM certificate, your test results, correct answers for the test, and a list of the references will be sent to you. So with that, I'm going to begin introducing our really eminent scholar, Dr. Reginald Munden. He is the Chief of Radiology at the Methodist Hospital in Houston, and he's going to talk to us about Akron studies, significance to practice of radiology, which is a very important topic. Akron has propelled radiology into really a lot of multi-center trials that establish radiology as a rigorous discipline. So, Dr. Munden.
Pushing the wrong button. Okay. All right, thank you. So I'm going to speak to you a little bit about Akron and how it's impacted actually my life as well as the practice of radiology. I think most of you are probably familiar with Akron, but in case you aren't, I wanted to make sure that you got this objectives of Akron. And basically, Akron was formed as an imaging network for advancing imaging and doing clinical trials in particular, and this is important to make note, for doing research and screening large populations and evaluation of radiology's impact on that. I hate these kind of slides with all this wording, but I really put this up here to point out two things that are in light blue. These are the DMIS trial and the Nlst trial, huge trials done by radiologists. Probably the Nlst is the most expensive trial ever done by the NCI, and I'll speak to that later. But just to show you that in 2001 and 2002, which is only about maybe 12, 13 years after the formation of Akron by basically Bruce Hilum and Constantine is under the direction of Ron Evans, who was ACR at that time. So tremendous credit to them that in 12 years, two of the largest studies ever performed in the NCI were done by radiologists. It's amazing how quickly and how well radiology transformed into that area. Akron has a scientific plan, as I mentioned, is to implement clinical trials, essentially to evaluate imaging in the context that was basically done for cancer, but there are a few non-cancer related things ongoing. And take note of number one, under the primary screening population, the high risk for cancer is an important focus, and that's what I'm going to speak to quite a bit. In the spring of 2001, because of the NCI designation, Akron was merged with ECOG. There are three primary programs under ECOG, cancer control and outcomes, therapeutic studies, and biomarker sciences. I think it's safe to say that we don't really know what the true outcome of this merger is going to be relative to radiologists, and this probably will impact us more than anything we probably could have in regards to running clinical trials, predominantly because probably the focus of ECOG Akron is going to be more toward oncology trials and outcomes, which radiologists typically are not the PIs in. So how you interface with and how you participate in clinical trials is going to change a little bit. And I think the outcome on that is to be determined. We certainly anticipate Akron has a very strong presence in that. Mitch Snarl is now the head of Akron, if you're not aware of that, and he is very, very integrated with this organization. So I'm optimistic about it. It's just that it's going to be different how we participate in these trials. So what Mitch talks about and what I agree 100% is if you have a concept, the most important part of that concept, if you want to bring this to Akron for a clinical trial, is the science. You have to have a good question and a good approach to it. If it's good science, you can do the trial and it will get done. Every trial that you participate in, you need colleagues and a team because of the size and difficulty of what we're doing, because we are usually storing images or acquiring images, and Akron has a wonderful team of experts to help you that. Develop that protocol and submit it through the process. There is a process of submitting a protocol in through Akron, and it usually goes through CTIP or some other organization to get reviewed. And having done that myself as a PI for a trial over about 2 years, that ultimately I transferred to Terry Wong at Duke because we couldn't get it through, and eventually after about 3.5 years it just got stopped. We never did the trial. Believe me, the team at Akron is critical if you ever want to do any kind of imaging trial. They were very helpful regardless of whether you get through or not. So what I was asked to do is talk about a couple of trials that have impacted radiology and what their influence is through Akron and how Akron helped us get to that. So the first one is the National Oncology PET Registry. Now this is not so much a trial or a process that was done for individual radiologists. It was more for validating a test, that is PET, and it was what the programs or institutions had to do to participate in this type of trial. So these are slides from the NOPR website. This was in response to CMS asking for evidence of the effectiveness of PETs and ultimately leading to the CMS coverage of PET, which I think Richard and others will speak to after this. So I don't want to talk so much about that process. I just want to talk about what the trial or program really was about. Basically, you had to be a Medicare-affiliated facility to participate in this trial. You had to do pre- and post-PET information from our clinical colleagues, not from the radiologists, but from our clinical colleagues to study the impact of PET on cancer. You can see there were a number of organizations. Obviously, ACR and Akron were forefront in this, were major endorsers of this, as well as supporting management. And Bruce, one of our speakers, was big on this, obviously, and he can tell you a lot more about this than I can. But this was a process that started. We were trying to get referring physicians' perception of how PET influenced their management of the patients, and hopefully by acquiring this data, we were going to be able to prove that PET was valid in a variety of cancers, not just lung cancer for the most part. Each facility had to have the clinicians agree to doing these studies and fill the forms out. And in, I don't have a pointer, but do we have a pointer somewhere? It's all right. And in the process of filling those papers out and going through it, and most important, as you see on the bottom, in typical CMS fashion, you did all this for nothing. You were not going to get reimbursed for doing this part. So everything had to be done, completed, pre and post test. The test was something of this nature. You know, why did you do the PET? Was for diagnosis or restaging or reevaluation, et cetera. And if the PET were not available, would you have done something differently than you did with the PET? So this is just collecting data through CMS. And then after the information was acquired, you filled another form out saying that management was impacted, yes, no, et cetera. So as a result, this was 150,000 cases over this period of time that were done in the PET registry. It led to the Journal of Clinical Oncology publication about PET, and if you're not familiar with JCO, it is the major journal of ASCO, the American Society of Clinical Oncologists, very high impact journal, and led to that publication, which ultimately led to solicitation and agreement by CMS to fund a number of different types of cancers. And so this is a big success, funded by Akron or supported by Akron, institutional-wide, not necessarily radiologist PI-wide, but was very important. And so a success for Akron in the PET world. I'm not a mammographer, so I'll be very brief about the DMIS trial, another large clinical trial headed up by radiologists, supported by Akron, to look at digital mammography screening. And if you're not familiar with it, I think most of you are, and started October 2001, almost 50,000 women enrolled, which is a huge number if you think about clinical trials. Most oncology clinical trials are 100 or so, maybe. So 50,000, 49,000 women at 33 sites. Tremendous. They did digital and screen film comparison. All of this was done by radiologists. People were enrolled by radiologists, consented by radiologists, and the results of that were published in the New England Journal of Medicine in September 2005. And subsequently, a lot of the, I guess, policies or utilization of digital mammography, basically it proved that it was better in dense breast. And as you know, today we have much more legislation and much more stuff coming out about this. Most people are, I'm not a mammographer, but I think it's safe to say a large majority of people are doing digital mammography now. I don't see many screen film mammograms around, although I'm sure they still exist. So again, 2001, massive trial sponsored by Akron with huge number of enrollees and great success. And many people, many radiologists participated in this in the level. So what I wanted to speak mostly to you about, because I was understanding there's some of you in here who are interested in how to participate in Akron, how to develop an academic career in Akron, and that's what I'm going to give you most of my time on, the National Lung Screening Trial. I was the site PI for the NLST at MD Anderson. I was on the I still am, I guess, on the executive committee of Akron for the NLST, and was heavily involved in, from day one of the program. And so I can give you a little bit of insight into it. And I think this is interesting for no other reason because I was involved in it, but also as a junior faculty member or even a faculty member, regardless of your career. At this time, in about 1999, lung cancer screening had been published by Claudia Hinchker and her group, and there was a lot of interest in doing lung cancer screening, but there was only single-arm studies, and for any modality that's going to be a screening trial, the experts agree that you need to do a randomized control study where you have the normal standard procedure and then you have the test experimental arm, and you run both groups and then look and see if there's any difference in mortality between the two groups. Claudia Hinchker and her group had done a single-arm study and had done survival, and most people will say survival is not relevant because you're screening people who don't have disease. When you talk about survival, you're talking about how long you lived with the disease. Well, we're screening people who don't have disease by definition. So in that scenario, you have to do mortality, and you can only do mortality if you do a randomized controlled study. So Akron was putting a proposal through. At the same time, the prostate, lung, colorectal, and ovarian cancer group, subgroup, the lung study section of that group, was putting a program through as well. And it was very interesting. My colleague at MD Anderson, Andy Van Esterbeck, had become head of NCI at that time. And Andy was a great understander of imaging. He really relied on this very heavily at MD Anderson, and I think that impacted his thought process at NCI, because he brought both of us together and said, you guys are both submitting the same kind of trials, but your numbers are not big enough. You have to combine the two and make one large trial out of it. That was the essence of his message, and he's much better a politician than I, and he said it in a different way, but the message was very clear. And so we formed this protocol group and called the Nlst group. The most important thing about it was that the large part of that group was epidemiologists and oncologists, and their sentiment at that time was just do the CT and we will take the data and analyze it. And so we got involved in that and said, no, not to be that way. This is an imaging radiology study. This is not an epidemiology study. So 2.5 years later, we actually got the protocol developed. And you can imagine the fun of doing that. And one of the things that we were adamant about, and Denny Aberle, God bless her, led this charge, and she really, really worked her tail off to get to this point. At that time, the standard imaging for most CTs was 7 millimeters. Some advanced academic centers were doing 5 millimeter slice thickness. We were adamant that we were going to do 2.5 millimeter slice thickness. Not only that, we were going to do a 50% overlap. So we were so far ahead of the curve with the imaging part of it that we had pushback from some of the radiologists in the group as well. But our sentiment was that single slice, and now we were on 4 slice, and however many slice CTs were coming down the pipeline, and we knew this would be an 8 or 10 year trial. We had to have imaging that would stand up in 2012. And so we fought and we fought and we fought, and it was so much fun that it lasted about 1.5 years to finally get that into protocol. So now we've made the emphasis, in my mind, of the Nlst on the imaging, not on the epidemiology. And I think that's a tribute to the huge group of supporters in the Akron, as well as the LSS arm, and the radiologists who were involved in that. Because frankly, we were pushed aside at the first meeting I attended by the epidemiologists who were running the whole trial. And so now imaging became a primary focus of the trial. And I think that's purely from the radiologists involved. We launched in September 2002. We had multiple sites with PIs at each site, and it was a wonderful learning experience. Or as what some people say when there's really dire, horrible circumstances of MLO, a marvelous learning opportunity. Well, it was an experience. Akron was designed, as I said, a randomized controlled trial. There was an experimental arm, which was the helical CT. And when you get involved in these kind of trials, you learn a lot. The control arm was supposed to be the standard of care. By everyone's recommendation at that time, the standard of care was to do nothing. You do not screen. Well, everyone felt that if we brought people in, gave some a CT, and gave others nothing, we would have huge drop-off in that arm, so we added chest x-ray. That was another 6-month discussion and argument, because the possibility that chest x-ray worked as a screening tool was still up in the air, although most people most publications didn't support that. But we decided you had to have a chest x-ray, and we ran the risk of the trial not working, because a chest x-ray might raise that standard to a point that we couldn't show that difference between CT and chest x-ray. Again, radiologists were instrumental in this protocol development, and it was a great experience. We had 33 sites across the US. The little circles are the Akron sites, the big circles are the PLCO sites, and it doesn't mean they were bigger, it's just the way it turned out. Akron was behind the game on this part because the LSS, or the PLCO group, had been screening people for about 2 years. So they had their mechanisms in place, they knew how to do it, they knew what they were doing with data, and they knew how to acquire data. So those of us in Akron started behind the curve, and we had to ramp up very quickly. But yet again, here's another trial, 53,000 people enrolled in the trial in 18 months. Think about that number, 53,000 in 18 months, all of it done by radiologists. And I can't toot our horn enough to say this is remarkable. Admittedly, some sites had pulmonologists and others involved in the teams, but the enrollment, every CT, there's 53,000 total, half chest x-ray, half CT. Many people got more than one study. So many of us, there were 29,000 CTs that we all sat down and graded and scored, and I'm telling you, the grading sheet was, as you would expect, probably 3 or 4 pages. It was a monumental amount of work that we did. So extremely proud of our Akron people. This is the timeline of when we did. We started 2002. In October 2010, we hit the target, and that's when the trial stopped. The reality is we actually stopped imaging in 2005. We did baseline, year 1, year 2 CTs, and then we just did annual survey of everybody afterwards. All of that data collection, all the annual survey, all the calling patients, sorry, they were participants because they weren't patients at the time, calling them, chasing down forms and all that, fell onto radiology departments for the most part. And I ended up with about 4 or 5 people employed by me to try and get this done over time. I knew nothing about running a clinical trial when I started, and I think it showed the first 6 months. I hired one person. The way Akron funds, just for those of you, and I assume it's going to continue this way, is you don't have any money up front. When you enroll someone, a few months later you get money for enrolling that person. So your startup costs are on your own. So my chair gave me some money to hire one person, and we opened the doors and we had 500 telephone calls the first day. We missed 90% of those phone calls. And to say we got plowed over in the first week or two doesn't do it justice. But we caught up eventually, but I think we missed the opportunity to enroll a lot more. And so this is what you have to think about if you're going to do a clinical trial, is that startup cost and how you're going to manage that. Obviously, those institutions that have Akron trials ongoing and are set up are better off than you will be if you don't, but it's worth doing because you can get involved into it. 20% reduction in mortality. We hit that target October 2010 basically by doing annual surveys, finding out people who had survived or lived or died with cancer. And was published in New England Journal of Medicine in 2011. So again, a monumental effort, monumental results. 2 major clinical trials, DMIS and NLST, published in New England Journal of Medicine. There have been subsequent publications around the NLST in the New England Journal of Medicine. And finally, the cost-effective analysis is in review, but probably will be in New England Journal of Medicine soon as well. So what's the fallout of the NLST? Well, the problem is we have answered a lot of questions, but we've probably created more questions than we answered. And this is the rest of my career and some other people's career for the next few years is looking at this data and going through it. The false positive rate of 96% is what has everyone scared. And we're doing a lot of efforts to reduce those false positive rates. So the end result of that trial was the publication in the New England Journal of Medicine, which now has a number of societies and places developing guidelines for screening, recommendations for screening. I think radiologists on every one of these committees for screening, which is, again, is a tribute to their efforts in Akron. And this American Thoracic Society Lung Cancer Survivor, that's another protocol that has been going through Akron, NCI, for about 2 years now, and we can't get anybody to agree on how to run it, but there is an NCI think tank now on how to run this trial and put it together that I just attended about 4 months ago, and hopefully that trial will get off because these people are at highest risk for having lung cancer. They've already had one lung cancer. So how do we screen them? How do we follow lung cancer survivors? And we're going to have tons of these people now because we're going to find lung cancer at early stage 1 and treat them successfully. These are NCCN guidelines if you're interested. Again, I hate these kind of slides, but another part of this through the ACR's effort has been to put together a committee of us together to develop basically a lung RADS that mimics BI-RADS. We desperately need this in lung cancer screening because we're all over the place on this. Despite the NLST having some guidelines, we need more rigid, stringent kind of BI-RADS, but we'll call it LU-RADS or lung RADS. Ella Cazzaroni is the chair of this committee in the ACR. And this is a credit. The ACR is doing a wonderful job helping us get this out. And we hope to have this out or some version of this in the next few months to help those of you who are doing lung cancer screening and, again, starting better data collection. The task force, U.S. Preventive Task Force, screening sent out a comment period. Basically, after that period, they recommend lung cancer screening and gave it a grade B recommendation, and I'm sure Richard may speak to this if you're not familiar. Basically, grade B recommendation says there's enough scientific evidence that this is recommended, and perhaps more importantly is under the Affordable Care Act, any private insurer is required to provide lung cancer screening or any grade B recommendation. So now private insurance has to cover lung cancer screening. CMS doesn't. They don't have to adhere to the preventive task force, and I think we'll have a talk about that. So CMS has a website open where they now have an open comment for lung cancer screening. Virtually all of us in whatever society we're in have submitted comments to this website to talk about it and hopefully get that approved through CMS. So that's the Nlst, and I'm happy to answer any questions later on about it. And finally, just a last comment about the virtual colonoscopy. I think all of us are well aware of the virtual colonoscopy. Well done, very nicely done trial, published in New England Journal of Medicine and basically ignored by CMS, not approved for coverage, gave an I rating. If you remember, I rating is not a good rating. This is obviously under major stress at the moment. There are a lot of new data coming out, but this was, maybe I shouldn't, this was a political denial, frankly, in that it was stopped not because of the science, but it was stopped because of politics, and I'm not sure if we're going to talk about that later or not. But. So, in general, that's what I think Akron has done for radiology. I think those are probably 4 examples of tremendous success in radiology, and not just for radiology community, but for me as a PI and as an investigator. And if you're the least bit interested in being a participant as a radiologist, I highly recommend that you come through the Akron process. Thank you.
Thank you, Reggie. We'll take the questions at the end because there's a panel discussion at the end. But for the scholars sitting in the audience, I would strongly encourage you to get involved with Akron or ECOG Akron at this stage. It takes many, many years. I can tell you 2 examples from what he has said and from my personal experience. I'm in the committee for Akron 6685. We wrote the protocol when I was a fellow. That was nearly 8 years ago. And the study probably would finish next year. So just to give you an idea, from the protocol to completion, it nearly takes multiple years. And I just appointed as a co-chair, imaging co-chair for another group trial, and that took just the approval process took us nearly a year. So I really encourage the scholars to get involved early in your career because these takes multiple years to come to fruition. With that, I want to introduce the next speaker, Bruce Hilum. I came to know Bruce about 4 years ago, part of the NOPR, the leaders. I really learned a lot from just listening to Bruce over the last 4 or 5 years in the teleconferences. He's a thought leader. He was the PI for the NOPR that was instituted many years ago, and you can see the result he's going to present. Without taking any other credit, I want to get started his talk so that he can give us
Morning. I'm a general internist, health services researcher who dabbles in your field as both a clinician requester of it and as a health services researcher. I was asked to talk about the idea, focusing on the CMS perspective of what they fund and translating scientific conclusions to radiology practice. I listed in the handout some objectives, but let's step back. This is targeting you as diagnosticians, not the therapeutic radiologist. As a diagnostician, establishing value of what you do, you have the same challenge as individuals in today's doing genetic profiling of all hosts of different traditional blood assays, and that the test, be it an image or a biologic assay, is a single node in a chain of diagnostic or therapeutic maneuvers. And attributing that the value of that single attribute in health outcomes is a challenge that is true for all the elements of diagnostics. In addition, a diagnostic may or may not be viewed as being valuable because it depends on, as I'll show you at the end, it's dependent on the availability of therapeutics that can impact a natural history. So, reader of the newspaper, you may be aware of the term reasonable and necessary. This is a couple of modifications from slides from one of the senior leaders at the Center for Medicare Services. This has not been defined in statute, that is in hard law. There have been at least 3 different attempts over my career where it's been attempted to be formally defined, and it hasn't been successful. And for practical uses, CMS operationalizes the following definition: adequate evidence to conclude that the item or service improves clinically meaningful health outcomes for the Medicare population. So, for a diagnostic, you need to have adequate evidence of incremental information compared to the alternatives that change physician recommendations, that subsequently lead to changes in therapy, that subsequently lead to clinically meaningful health outcomes and in Medicare beneficiaries. From CMS's perspective, and I think it's true for all the major insurers, the power is on the left, not the arguments that are commonly used from the right column here. That can you show that there's going to be patients involved are going to have a longer life and or improved function, ideally a longer life with a slower trajectory of decline in the interval of life, or a major symptom reduction allowing better function, and you avoid the need for burdensome tests or treatment. You're going to fall on deaf ears if you take the classic argument that the images look better. That if you say the referring physician is more confident, that the surrogate test result is just intrinsically better, will not get you anywhere. And don't be surprised where you have deaf ears. The challenge is that it doesn't matter what the technology is that there's a natural history that goes from the left to the first technical introduction or discovery through a series of steps. And I'll touch a bit on FDA approval, which is different than Center for Medicare Services coverage, to broad acceptance. So I'm going to talk and overlap some of the first presentation, and I'm going to lead off with my interpretation of the CT colonography story. Then I'm going to touch a little bit, but not too much, about NOPR, which I was the head of, and comment about beta amyloid imaging. Well, as you heard, virtual colonoscopy. This is following a traditional bowel prep similar to a colonoscopy, an oral contrast. The colon's inflated, an abdominal CT is done in 2 different positions while the patient's fully conscious, and it is inherently an intermediate test in that the clinically important polyps and or potentially the much less frequent large malignant mass can only be subsequently confirmed and by referral to endoscopy or surgery. So the chain of events, I think you're well aware of, but it's complicated in that individuals of some threshold age of average risk, be it 40, 50, 60, undergo potential screening. The options that currently are available in the United States are screening endoscopy, FlexSig, CT colonography. The FlexSig or CT colonography, if abnormal, will lead to a diagnostic colon where the polyp is potentially removed and or colorectal is diagnosed, subsequent surveillance, etc. CT colonography, the discussion here is solely about the screening use. In 2008, there was the reported, as you heard earlier, several large clinical trials. The Center for Medicare Services, prior to making its final decision, had a conference called the Medical Evidence Development and Coverage Advisory Committee, called MedCAC. And they were specifically asked the question, based on the available evidence, how confident are you, this is to the panel of experts advising CMS, that screening colorectal CT colonography results in a net benefit? And on a 1 to 5 scale, it was sort of in the middle of the road. So going forward, there was some doubt about how CMS was going to decide. And as you heard, there was this major trial done by Akron, completely appropriately to be applauded, with a large number of patients, 2,600 individuals over the age of 50, and that published in the New England Journal in 2008. With sensitivity, specificity, you could calculate the number needed to be screened to detect one event. But there's a problem. Why CMS led to the following conclusion. The findings of the trials showing a benefit in screening with this method were not necessarily generalizable to the CMS study population. CMS noted that the mean age of participants in the trial were cited for support of the coverage was significantly lower than Medicare beneficiaries using the traditional age 65 and up tradition, of retirement, not coverage for disability. There were no studies reported evaluating this technique limited to the elderly, nor were there subset analyses of participants over the age of 65. So so when you actually look at dig into the numbers, does CMS have a point? You look at the top rows, the mean age is 58 to 60 of individuals in the trial. The interquartile range, meaning 25 to 75%, just touched 65. So 20 to 25% of the participants in the trials would be 65 and older to be the group that would be appropriate for the interpretation of making an informed decision. In addition, the rates in minority participants in the trial was very, very small. So as you heard, that was 2008, 2009. CMS 5 years later still stands by it. The current status is that the U.S. Preventive Services Task Force is revisiting the evidence, and as you also heard, that if the recommendation comes out A or B, that the health plans under the Accountable Health Care Act are required to cover the service. And CMS would be part of that. But it's really going to be based on an expansion of that information that's available for the population of interest for Medicare beneficiaries, that is the elderly. For many major United Healthcare Plan, Anthem, Blue Cross of Virginia are the two that I know best because they're the largest private sectors in Virginia. For individuals over age 50 to 64, they do cover CT colonography, that they do accept this level of evidence because of if matching that element of the age population. But this is the premier example of currently where CMS translation of reasonable and necessary does not necessarily fit with an untarnished or narrow look at the data. What about PET and solid tumors? To go back, that PET, the evidence has been accruing since over several years. The younger people in the room don't recognize that PET has literally been around from its first biological concept 30, 35 years. It's had a long, long legacy. Randomized trials using PET have never been done in the United States. So that the gold standard of its use is quite limited. That CMS, in deciding its role of using FDG PET in cancer diagnoses, did not choose to make a recommendation that it would consider cancer. It considered cancers. Colon cancer is different than lung cancer, which is different than lymphoma, etc. So in addition, that the evaluation of a solitary pulmonary nodule where the issue is diagnosis is different than suspected cancer recurrence. So that there's a lot of matrices there. You have tens of different cancer types. You have tens of different, or not tens, but 4 to 5 major indications. And each of those, that the structure was that it was working towards covering it on an individual stepwise basis. So it was kind of a catch-22 situation. As of 10 years ago, that there was cancer for the top 6 cancers at the top: non-small cell lung, esophagus, colorectal, lymphoma, malignant melanoma, and head and neck. Everything else was off the table and breast was covered for advanced restaging, and then the other ones here. But you had probably we estimated at the time 30 to 40% of the burden of cancers in the United States, PET was not available. So coverage that is payment by the facility and the interpreting physician for doing an FDG PET was made available, as you've heard, if patients participate and data was submitted to a national registry. What you may or may not be aware of is that the Center for Medicare Services currently requires a whole lot of registries. Many of them that you may or may not be aware of because they're more therapeutic. But the Icd Registry, there's a lung volume reduction registry, that there's examples shown on the left to enhance the data collection and knowledge. NOPR's intent was to provide services not currently covered by Medicare, lead to change in patient management, and have reasonable data quality. I don't think, given what you've heard already, I'm not going to go into it too much, but highlight that the change in intended management comparing pre versus post was about 1/3 of cases, with more commonly a change from non-treatment to treatment being about a 3-to-1 ratio, but the impact based on the indications was actually quite consistent. come on back, pointer. So the consequences are that CMS has now gone a little bit more refining, that the coverage for diagnostics in cancer, they distinguish between initial treatment strategies versus subsequent treatment strategies, and that last year they've raised a highly controversial bar that this is for the first time that I'm aware of that they have explicitly suggested that a diagnostic has a lifetime limit, that for subsequent treatment strategies, patients will have a 3-scan limit, and scanning beyond that will be at the local carrier discretion. This is a saga that I think the story is playing out, but I think that this is bringing it to your attention because this is a trend. There's nowhere else that I'm aware of that, for example, if this trend is going to go forward, and if you have had a myocardial infarction, you're allowed 3 subsequent nuclear medicine evaluations for suspected recurrent coronary artery disease. What about beta amyloid imaging? Maybe you don't even know what beta amyloid imaging is. Well, this is an example of where you're going to, in your careers, learn some of the acronyms in regulation. The Federal Drug Advisory Service defines safe and effective for proposed use where the benefits outweigh the harms of drugs. And what's relevant to you is that nuclear medicine isotopes are, in a regulatory perspective, a drug. CMS is payment for, as we've heard, about reasonable and necessary. There are other terms that what's called a 510K generational improvement. That is, every time that there is a subsequent improvement in some of the technology that you just take for granted, for example, an upgrade on a CT scanner, that new model doesn't have to go through the regulation process because it's viewed as being at least as safe and effective as the existing marketplace. So therefore, going from a PET scanner to a PET CT scanner doesn't require a new regulatory environment. There's other factors around high-risk devices that I'm not going to go into, but again, the new NDA, a new drug application, is regulated by FDA for all nuclear medicine tracer isotopes. So that you may think that you're a diagnostician, but the therapeutic world crosses over to your side. Well, there's a recent report about CMS's decisions compared to food and drug approved things. Approximately half the time CMS's decisions are more restrictive. Occasionally they're less restrictive. Beta amyloid imaging, there's 2 isotopes when I made this slide 7 to 10 days ago. A third was approved. Our imaging biomarkers for amyloid deposits in the brain, but CMS had a national coverage decision last year that said it would only cover this service if people were participants of a clinical trial or a registry. And you can say, well, how can that be? The problem is that CMS's perspective is that having an improved diagnostic for a clinical condition that you have no available therapy to modify the natural history does not lead to a subsequent improvement in patient outcomes. So the PET nuclear medicine and the Alzheimer's Association are working together to try to develop a potential registry to follow the tradition of the NLPR, to go forward to allow to get coverage within a registry for patients with this. But the challenges are much more, I think, complicated than the cancer situation. That, for example, one of the primary indications that the advocates for beta amyloid imaging suggest is that for individuals who have early onset cognitive impairment, but if that individual and situation is under the age of 65, we get to the same CT colonography story, that major indication, CMS would say it's not our bailiwick of beneficiaries. Should we be targeting individuals, how much cognitive impairment, be it mild cognitive versus atypical dementia? It's not clear what the algorithms are supposed to be once you find it. There's no historical good control data. And to be able to look at the impact of the subsequent natural history, it's not a 3-day or 30-day, it's more likely a 12 to 24 months minimum duration of follow-up that would be required to be able to find a change in the natural history. So those are some examples that, and look forward to your questions later. Thank you.
Thank you, Bruce. So we have gone through the problems of discovery and then regulatory hurdles that we need to overcome to translate a imaging discovery into practice. And the next talk is going to be delivered by Richard Dusak. He's the Vice Chair of Health Policy and Practice at Emory, and also he's the Director of the Harvey Newman Health Policy Institute of the American College of Radiology. And he's going to talk about how do we influence the policy to support the practice. How do we make all this to happen at a very high level? Welcome, Dusak.
Thank you, and thanks for allowing me to be part of the program. I'm going to take a quite a different angle on my comments than the last two speakers. A lot of it really dabbling from how we go from the scientific world into the political world. While we may not like it, that is the realities of the environment, and I think how thoughtful researchers will have the most impact with regard to not only their work for themselves, but also for the specialty and the practice of radiology. I have no financial conflicts, but I will make a couple disclosures here. First of all, after 20 years in private practice, I sort of wear as my badge of honor is I've never participated in a clinical trial, probably never will in my career, just because of the trajectory that I've taken. That's, that may be good, it may be bad, it's just a different perspective, and so I want to just warn you that I've got sort of a different perspectives on some stuff. I have had a few people refer to me over the last few months, which I had never thought of, is that I'm a policymaker because I serve on the executive committee at the CPT editorial panel. I've never really thought of it exactly as a policy maker as such, but if you say that getting a CPT code is the first step towards ultimately getting paid for a service, then I guess I sort of wear that hat. I'm not sure that's as much the case as much as I interact with a lot of people in that sphere. I must tell you, they probably don't have the attention span necessarily with regard to a lot of the scientific stuff that we heard from the last couple speakers. And a lot of these decisions wind up being made in a bit more of an emotional sort of big picture perspective with regard to coverage. And so I will share with you some thoughts there. One of the things that's obviously a hot topic for a lot of people, I know we've got a lot of the scholars in the audience and other people, is translational research. How do we go from bench to bedside as quickly, as efficiently as we can? In perhaps my simplistic view of the world, I refer to that as translational research 1.0, which is sort of the traditional model. And it's incredibly important for what it is that we do. What I think we need to be doing collectively more effectively as a specialty is really getting into sort of the 2.0 arena. And again, we've heard the other speakers allude to pieces related to this, which is, how do we go from the sort of how it happens to what happens to the next steps of, how do we make these things work for the public at large? How do we influence policymakers to pay for more of this, critically important, and to help us implement these types of technologies more effectively into our clinical practice so that we can deliver the best care that's possible. It's what I refer to colloquially as applied health services research. Really, it's not only the research itself, but it's also some of the messaging, which I think is critically important when we think about how do we influence policy moving forward. And so I'm going to share with you some perspectives from things that are a little bit foreign to a lot of physicians out there, which is sort of how the sausage gets made with regard to payment policy, and share with you some of the message that I think are resonating most right now with decision makers that are out there. When I used to chair the coding nomenclature committee for the American College of Radiology, I'd probably get 2 members a week call me with this: I want to get paid for more, just get me a code. And so I spent a lot of time talking about the fact that a CPT code does not immediately translate into payment. And so we've got a physician's perspective of the world that, we did this, it's really good, it works, look, the sensitivity, the specificity are all really good, just pay me for it. Unfortunately, and again, we've heard some of the messages from the last couple speakers, there's a complicated chain which I don't have enough time to talk about this morning between just doing it, whether it's doing the research or doing the actual service, and getting paid for that. And there's a lot of ways, and we heard some of those stories as to how that chain gets broken. And so one of the things that, as I started getting involved in the advocacy world probably about 15 years ago, and would attend a lot of scientific meetings at RSNA and the like, and sort of raise my hand from the back and ask some questions, I'd sort of get these, well, it's not about the money. Well, you know what? To some extent, it is about the money. In fact, it's always about the money to some extent. Whether you're a researcher, you need the money to pay to do the research that's out there. And even if you're in an academic medical center, we've heard a lot of times, a lot of us use within our own strategic planning sessions, no margin, no mission. I mean, it may not be about capitalism for ourselves and our own money, but we do need those funds to continue our missions moving forward. And so we are at an interesting time where I think that we're seeing the intersection of health policy and our own clinical practices, whether private or academic, is focusing more on the dollars than it has in the past. And I'm not saying that's necessarily right or wrong. I think that's just the political reality of where things stand these days. And as somebody who's recently transitioned from a private practice into an academic medical center, I spend a lot of time worrying about things like this. This is a white paper by PricewaterhouseCoopers, looking at academic medical centers in general, and sort of where our dollars, my pointer, there it goes. And you look at the typical distribution in academic medical centers in general, and a lot of our clinical money winds up supporting these other important messages that we have. I'm sorry, I'm having some sort of pointer troubles here. Yeah, kind of, okay. Transitioning. What's on that screen is not on this screen. Take my word for it. I really am not as uncoordinated as I look right now. Okay, well, anyway, we'll see if we can work around there. So anyway, as our clinical dollars are contracting, our grant dollars are contracting, I mean, it puts us in a very precarious situation that, the downstream of those, our educational missions, our clinical missions, our research missions, all get a squeeze as well. And so is to talk about some trends in healthcare utilization and spending, and what I see is some potential win points, win themes for the future for us collectively. I think we've all seen graphics that are out there demonstrating that we are on an unsustainable trajectory with our healthcare spending. There's data that are out there with projections that, come 2027, if we don't do anything about what we're spending on healthcare, it's going to consume 25% of our gross domestic product. Clearly an unsustainable trajectory for us moving forward. And, you know, one of the pieces there, and I think, again, we've heard, you know, and we saw a lot of data like this that are out there. This is from the New England Journal from John Eigelhart a few years ago, basically saying that, you know, imaging's at the bleeding end. All this money, you know, if we could just cut down the spending on imaging because it's way up here at the top red. I'm not going to move my pointer here. I'm not going to jinx myself. But the red line here, that basically we can cure all of healthcare's woes. And I don't think it's quite that simple. Dave Levin and Vijay Rao are here. I mean, they've done some great work, as some other folks in this space, saying, you know what, that trajectory of medical imaging really has slowed down here. And I think we do have a bias of policymakers out there that are saying basically imaging is bad because it costs a lot of money. And there's been some other data, some from our shop, and this is some data that we worked on with David Lee, who's one of the health economists from GE, that showed in recent Beto's category spending from 2001 that imaging used to be way up at the top, but way down towards the bottom right now. And again, sort of a messaging, I think the mythological messaging that's out there, which is that, you know, imaging costs a lot of money. Sure, there is a lot of money being spent, but it's no longer the big driver that it used to be in the past here. So anyway, other things in... and so other things, of course, all of us have felt as well in the world. But anyway, you're trying to get back on track here. So, you know, context of that, as we're feeling sort of pressures on our own salaries, but also our payments back to our departments as well, the National Commission on Physician Payment Reform came out with a report just last year talking about, you know, what we need to do to fix the physician component of healthcare spending. And they used a graphic in there that I think should be a big waking point for all of us here, looking at physician salaries that are out there. If we look at the sort of the top line here, they're basically pointing out radiologists and cardiologists as big spenders for compensation. And the other piece to remember with regard to, you know, a lot of the people that are making policy out there, you know, their salaries as internists and family practitioners, and this is a piece that's always unpopular to remind a physician audience, but, you know, we really are in the top 1% of all players out there. And so there's a huge amount of bias towards saying, you know, physician salaries really should be living down here. And I use salaries as the surrogate, but also as well spending on all the services that are associated with imaging as well. And so a lot of people are out there saying, you know, we need to fundamentally revisit the way that our healthcare system is being paid here, and that we've been on this trajectory in the past. And you'll, I think, hear from this from Dr. Allen at the noon session, you know, where we've been getting paid for the volume of our services. Volume is really good. The more you can crank them out, you know, the better it is for your practice, the better it is for the department, the better it is for your bottom line. But I think, you know, as we've heard from a couple of the speakers this morning as well, you know, we really do need to be looking at the value of these new technologies, the value of these services, and I think really a lot of the mission that we need to be thinking about in promoting what it is that we do is really focusing on the value proposition of these things so that we can make that transition as successfully as possible here. And so, you know, we could have a whole separate conversations on defining what value is. And again, remember, a lot of these folks are looking for talking points out here. So, you know, I don't want to drag you down into the weeds of too many detailed equations here, because I think some of the themes of the messages are important. But basically, we're talking about bang for the buck. Are we improving quality and reducing cost at the same time? And if we do those things, we're going to find a political milieu that's much more receptive to whatever it is our messaging is moving forward. And so there's a lot of nuanced ways that we can look at some of these things. And I've had the benefit over the last year and a half working with the Neiman Health Policy Institute. Our chief economist and econometrician, Danny Hughes, is in the audience. And so I've learned a lot from him with regard to a lot of these types of concepts here. Is, you know, even when we're talking about things that sound really simple, like costs, you know, most of the time we're talking, well, and, you know, charges very different than cost, but we're talking about cost to payer. But there's lots of other ways of measuring cost. You know, what's the cost to the patient? I mean, what I pay for a healthcare service personally out of my pocket is very different than what my employer is paying for it when there's issues of deductible, co-pays, things like that, which may be different than what the insurer is paying. Certainly the costs of delivering these services particularly as our reimbursement is changing, as practices, whether physicians or facilities, is different sometimes than what we're getting paid by the insurance company. Hopefully they're paying us more so that we can actually break even on these things. And there winds up being all these potential conflicts out there that I think are huge opportunities to try to align these types of things as we're talking about value. Really brings us back to value to whom? Different people perceive value in different ways. Quality as well. There's a lot of focus, and I think appropriately so, on new technologies of looking at outcomes for a lot of the metrics that we heard about this morning, but other things that are increasingly important in this era of patient-centered care or service. And so one can provide, the same outcome with better service, and in the perception of the patient, who's the decision maker, or in the perception of their employer or the payer, ultimately the people making those payment decisions, the quality is improved. So I think these are opportunities to think about new ways of thinking about what quality is. Waste, if we can reduce waste, people are going to like that. That's going to be perceived as higher quality. And waste can just be, I spent 2 hours in your darn parking lot trying to find a spot. Soft metrics, but important metrics. One of the most important, and I know Bib will be talking at noon about clinical decision support, somewhere in there is appropriateness. If you do the study the best way in the world, you provided the absolute best interpretation on that, or you've got the newest technology, but you didn't need to do the thing in the first place because the question's already been answered, then what's the incremental quality? And I think these are huge opportunities for investigation moving forward. Michael Porter from the Harvard Business School, article that's getting a lot of attention, the strategy that will fix healthcare. I'm not sure it's the holy grail here, but basically he defined value as healthcare outcomes achieved that matter to patients relative to the cost of achieving those outcomes. Matter to patients. We are getting into a very different era that what's important to us traditionally as physicians isn't what necessarily is important to the people making the decisions moving forward. And so while we don't really have, good metrics for all of these types of things, I like to think about this quality and cost piece, because this is how people are conceptually thinking about this as a 2x2 matrix. We want to be providing services, or if you're doing research, you want to be thinking about these things as part of your metrics and things that you're looking to message down the road. Does it improve quality and reduce cost at the same time? We want to make sure that we're not in this quadrant over here. And then we've got lots of hand-waving to do in our commentary with regard to, well, fine, we've got some social decisions to make. Yes, it did improve quality, but what, the cost went up as well, and we get into some complicated discussions of things like qualities there. And so while we've tended to look at a lot of the ways that we measure how good things are from our perspective, I think we do need to be thinking about these things from the vantage point of other people as well, and doing that on the ground floor when you're designing your projects and really thinking about where am I going to take this to make this as meaningful and impactful as I can. And so when I went to medical school in the 1980s, we were sort of finishing up the era of perhaps eminence-based medicine. You did it because that's what the chairman of the department said you did. And we started moving into this era of evidence-based medicine. And again, for the researchers in the audience, I'm oversimplifying things here, but the focus was, is it good? Is the sensitivity, specificity, whatever your metrics of outcomes. I think we're moving into an era where some of the opportunities that we want to be thinking about to be able to make that transition from how our research impacts care to really impacting policy, because that's how it's going to get promulgated out there. Is it a good deal? And so I think we do need to be thinking about a lot of these value metrics as part of what we're doing moving forward. And sometimes you can't always do those, but sometimes those are things that if you think about on the front end that you will be able to do out there. And so I think there's lots of opportunities that we've had, and certainly the Imaging 3.0 campaign that you're hopefully hearing about from the ACR is that we need to be providing value in our practices and our daily clinical practices, but I think one of the huge opportunities out there is to demonstrate the value. And it's just not good enough anymore to just say, I'm better than somebody else. We need to define what value is, and we need to measure that we are providing incremental value. And some people will say, well, what are those metrics? I don't know what they are. And to some extent, I think this is a bit of a blank slate. I mean, a lot of people are dabbling with this And I think that, while you can say, well, what do I measure? I don't know how to define these endpoints. I think it's a huge opportunity to say, let's let radiologists define what the metrics of value are and get it out there, but at least start thinking about some of these types of things that are going to be the ones that really resonate with the target audiences. And so, again, encourage you to be thinking about target audiences of your work and the things that we're doing out there. Again, okay, what's going to get you published? That's real important there. We need to appeal to the target audience of physicians. We are in an era where patients matter. I mean, ultimately, that's why we all went to medical school here. But I think we need to think about, what are the messages that resonate to health systems, to payers, potentially other researchers. You got to get some funding for doing these things. And those messages are not necessarily all the same with regard to what is value. And so I think the win stories really are going to be able to find themes of defining value that resonate with as many of those stakeholders as possible. Now, one of the concepts I've started as I interact with a lot of people in this space and have started fleshing out on my own, and I'm still trying to get at, how do you do all these kinds of things and influence as many people as possible with your work? What I've started referring to is the terrible triangle, that I'm not sure how you reconcile all these things. Everybody's focusing on cost, and I did say, when people say it's not about the money, it is about the money. I think we do need to be thinking about that in a dollar-scarce environment. We need to be thinking about reducing cost, improving quality. I mean, effectively, we're talking about that value equation. The other piece as well, projects better there than here, is patient access. I mean, this isn't really sort of the piece that's out there that everybody's talking about now, but people will increasingly be talking about this right now. I think the short-term message is cost and quality. If you can do access and improve that at the same time, that's great. I've got a problem figuring out in a sort of finite world of a bunch of variables out there of how the Venn diagrams entirely overlap, short of sort of really doing some innovative changes here. I mean, you can improve a couple of these, but to do all three at the same time is really, really difficult there. But I think these will be potential win stories moving forward for people if you can start defining value in those types of ways. Again, influencing decision makers, policy makers, and folks in that space. So I know I'm sort of throwing out a bunch of ideas that may not be conventional to people here. I would encourage you to at least think about, and you may think about it and dismiss me as crazy here, but I think we do need to be thinking outside the box a little bit from a point of view of really maximally influencing policymakers from the get-go when we're thinking about projects rather than trying to do that on the back end with the messaging. So if you don't like the metrics that are out there, for defining value, because there really are not great ones that are universally accepted, create some of your own. Discussions that we've had with the chief medical officer for the innovation group at CMS, I mean, they're very interested in seeing some proof of concept validation initiatives for defining value within our space because nobody really has successfully done it. So I think huge opportunities for basis work, for PCORI-based funding. Think about partnering outside of the box. We tend to work within our own comfort zones, but if you've got economists in your school of public health or other people like that, I mean, they're going to teach you stuff and that you've never thought about before, and they're going to challenge you to think about things in very different ways. And the other, I think, piece that's ultimately critical with all of this is that we do need to be thinking about messaging from the front end with everything that we do, and I'm speaking mostly to the folks that are in the academic medical center environment, which is the large amount of attendees there. But, okay, fine, we've got messaging to our local stakeholders within our groups. How do we sell this and sort of do our own practice marketing there? But how do we get sort of these messages out there to the academic community at large, getting a lot of other people thinking about these value messages? Because ultimately the messages we need to be thinking about are what's going to sell to policymakers, which again, sometimes a bit different than the way that we think about things. And so, again, some different ideas for things. My goal was to be a bit provocative here, more so than informative here. Paraphrase Darwin, that it's not the strongest of physicians that survives, nor the most intelligent, but the one that's most responsive to change. And I think we are in an environment that the people who are going to succeed as leaders of their specialties, if we want those specialties to succeed, are going to start thinking about doing that messaging, sort of going that 2.0 route sooner. I mean, some of this is our own self-serving bottom lines for ourselves, bottom lines for our department as well. But I think a lot of other opportunities that are out there, with new grant money. I mean, the Innovation Center's out there. It's got a lot of high-dollar awards. PCORI, Rathan shared with me a couple weeks ago, which was a real wake-up call to me, that there's more new PCORI dollars out there than there are NCI dollars out there. I mean, it really changes sort of the approach of, oh, wow, patient-centered, we may not be, feeling all warm and fuzzy and feeling the love of this patient-centered research, but there are a lot of dollars if you want to be in the space and doing these types of things. And so I would encourage you, as sort of, some of these types of concepts, of thinking a little bit differently about how we do our projects. And I'm not necessarily saying that everybody's going to sort of buy into the political spin on applied health services research, but do consider these types of things downstream if you want to really leverage your projects as much as possible. You see the quote from the general there, of sort of going to the next step here and really, thinking about messages that are going to resonate most with patients, voters, people who are paying insurance. They're all the same. And policymakers, because again, they're the people that are funding these types of things and making the policy decisions at large. And so my wrap-up slide here is, again, just think about value. I think if we want to say, back to my core question that I was asked today is, how do I think that what we do in radiology impacts policy? I think the hot topic right now is value, improving quality, and reducing costs. And if you can think about doing things and messaging that well, you're going to be very successful for yourself and for the specialty. Thanks.
Thank you, Rich. So we are now open to questions. We have about 10 minutes before lunch. So any questions, please come to the microphone so that we can hear it.
Bruce, I have a question for you. I'm Bibb Allen, by the way. I'm not positive we've met, but thank you so much for all you've done for the NOPAR and all of that. I heard a comment, and I can't remember whether it was from Marcel Salib or whether it was from Steve Furrow. But when they were confronted with what happened with the PET registry and the scientific basis for expanding coverage for PET based on the fact that it changed management's decisions. I don't know whether it was an offhand comment or whether it was official, but the comment was like, well, that's the last time we'll use change in clinical management as an outcome measure. And do you have any comment about that? Have you heard similar things, and are we going to have to come up with some different standard? Because in imaging, we're sort of constrained by that's sort of the best we can do. We can detect disease and then we can influence the outcome. So what should our endpoints be if you think Steve or Marcel was serious when they were talking about that?
So put that in a bit of context. The NOPAR registry, you were requested 4 years ago to do a PET scan for suspected recurrence in a woman with previously diagnosed ovarian cancer, 68 years old. The only way that scan would have been paid for would be if that scan was done at a CMS-approved facility where before the scan was done, the referring physician completed the information for the pre-PET NOPAR plan form, which asked if the PET scan were not available, what would be your management plan for this woman? That had to be documented prior to the scan being done. The scan is done in the usual manner. The report is delivered to the referring physician, and within 30 days of the scan being done, typically more likely we had 50% of or so data back in 5 to 7 days. The referring physician answered the question, now in light of knowing the results of the PET scan, my subsequent intended management of the patient is X, Y, or Z. And the key clinical evolution that I think is coming is that the nature of the registry recorded my intended management is going to be X. And I think going forward, that the answer is more going to be what was the actual management within a short interval. Because the intended management does not pull into the consequence the acceptability to the patient, the feasibility of doing it, that both as the treating or caring for physician, you recommend a course of action, but that doesn't necessarily mean it's the action that's subsequently taken. So that we've done some additional work with the registry where we've shown that about 80+% of the time, the intended management for initial treatment strategies in NOPR that Medicare claims reinforce what the management plan suggested. However, for individuals with recurrent disease, suspected recurrent cancers, that the claims are maybe 50 to 60% reflective of what patients are actually have done. And that's because the honesty of the recommended plan for individuals typically with a higher burden of illness, comorbidities, more recurrent cancer, what is recommended doesn't necessarily mean it's what's done. So that's a long-winded answer, but the answer is going to be that I think the standard's going to be within, depending on the situation, how long a time frame you care about, but what is the actual action that is done within, I think, 15 to 60 days.
I have two questions. First, about the colonoscopy, virtual colonoscopy. The point was that Medicare thought that the patients they're serving were older than what the numbers were shown in the virtual colonoscopy. But what about the Medicaid patient? I mean, it's the Center for Medicare and Medicaid, and Medicaid patients do overlap with the age group that the virtual colonoscopy was covered, I would assume.
I'm not disagreeing with your logic. I just don't have an answer for you.
Okay, so that's one. Maybe we can go back to them and mention that. The other question is going back to Akron. With Akron, I was involved in an Akron-sponsored study related to hypoxic imaging and glioblastoma multiforme. One of the most difficult issues that most departments face is the startup funds that you mentioned. It's hard to kind of ramp up the studies. Is there any movement in Akron whereby they will provide startup funding for the departments? Thank you.
I don't know of an effort. I do know that in the Nlst we had some subsequent parts of the trial we needed to answer some questions, and they gave a small amount of money to subsequently pay for that. Most of us ran out of money during the trial, and they wanted to collect more data later, so they came up with funding, seed funding money. But with the merger with ECOG and Akron, I'm not sure how that's going to play out right now, and I don't know that there's anyone in here that can answer that question, but I think it's unknown to all of us, frankly.
Yes. So I have done Akron trials at least in 3 different institutions, and it's the same catch. Somewhere you have to come up with a mechanism where you would do the IRB and have a research associate or fellow involved with the trial, and then you start accruing, and after you start accruing, started submitting forms, then only the money started to come in. So that initial sort of phase sort of relies on the departmental funding or the divisional funding or volunteer work from someone, or I subsidized. I had pharmaceutical trials running at the same time as Akron trials, so I got the money from the pharmaceutical trials to subsidize my research associate and the IRB work to start up the Akron trials. So that's so we have to come with some sort of mechanism like that. There's no sort of Akron funding or ECOG Akron funding.
Yeah, no, I would just add, I'm the chair of the academic department, and I think that's part of the chair's job to try and seed some of those small projects like that. It doesn't take a lot. It might take $30,000, $40,000, $50,000 to get a study coordinator and whatever else you need to do it. The problem with most Akron trials is it's not a full-time job for anyone, unless it's massive like DMIS or Nlst. So a small trial like the GBM trial, you probably needed a 20% person. So what I've done as a chair is create a one FTE that does all the Akron trials, and then you want to do a trial, you kind of tag in and tag out. That's probably the, so I would, if your chair is serious about research, most of them can find some seed money to start, or you build that infrastructure. It's a very distinct difference between us and our oncologist friends, where they have multiple clinical trials and they have nurses and everybody sitting there. Oh, they're not sitting there, but they're already established, so that where they just tie a new trial in and tie in and out. So I think a lot of that falls back on departmental chairs if they're serious about research.
Any other questions? Since we are 12 o'clock now, I'm going to conclude this session. I just want to remind us, two announcements I want to remind. One, if you are SAM, please hand in this sheet outside in the table. That's the only way you will get the SAM credit. And the second one is for scholars and others who registered for the lunch and keynote, it's in the Harborside Ballroom B. So we need to go over there for the lunch and keynote address. Thank you for all the speakers. Thank you very much.